The topic for this video would be cholinergic drugs. The neurotransmitter of the parasympathetic nervous system or the cholinergic system is acetylcholine. Acetylcholine is secreted from cholinergic neurons, and this acetylcholine binds to cholinergic receptors. The cholinergic receptors are of two types, muscarinic and nicotinic. Stimulation of these receptors lead to the mediation of cholinergic actions. When we talk about cholinergic actions, we can refer to these actions as vagomimetic actions, parasympathomimetic actions, actions of anticholinesterases, or actions of cholinesterase inhibitors. In general, these actions are simply opposite to the adrenergic or sympathomimetic actions. Now, we know that the muscarinic receptors of therapeutic importance include M1, M2, and M3. We know that M1 receptors are present in the autonomic ganglia in the central nervous system, where upon stimulation it promotes learning and memory or improves cognition. They are present in the gastric glands. Upon stimulation, they cause increased release of hydrochloric acid, and they are also present in the vestibular apparatus, where excessive stimulation leads to motion sickness. We know that M2 receptors are also present in the heart, and upon stimulation, these receptors cause depression of the myocardium. M3 receptors are present in the longitudinal fibers of the ciliary muscle, and upon stimulation, it causes opening of the iridocorneal angle, resulting in increased drainage of aqueous humor, which ultimately causes a fall in the intraocular pressure. M3 receptors are also present in the circular fibers of the ciliary muscle, and upon stimulation, it causes a general reduction in the radius of the eyeball. The lens ligaments tend to relax, causing the lens to bulge, and this results in accommodation of the lens. M3 receptors are also present in the vascular endothelium, the stimulation of which causes vasodilatation. It is seen in the exocrine glands. Upon stimulation, there is increased release of the secretions from the glands. They are seen in the beta cells of the pancreas. Upon stimulation, it causes increased release of insulin. And finally, M3 receptors are present in the sphincter pupillae, and upon stimulation, it causes meiosis. Cholinergic receptors are also nicotinic receptors, and there are two forms of nicotinic receptors, namely NM and NN receptors. NM receptors are present in the neuromuscular junction, and upon stimulation, they result in the formation of N-plate potential, the so-called threshold potential. NN receptors are seen in the autonomic ganglia, and they help in the conduction of nerve impulses. Now, drugs that produce cholinergic actions may do so in two ways. Some drugs can inhibit the degradation of acetylcholine. This results in an increase in the plasma levels of acetylcholine. More acetylcholine is available to stimulate cholinergic receptors, and this results in increased cholinergic activity. Such drugs are called indirectly acting cholinergic drugs. Some other drugs can bind directly to cholinergic receptors and stimulate them and cause increased cholinergic activity. Such drugs are called directly acting cholinergic drugs. The vast majority of cholinergic drugs which are of therapeutic importance are indirectly acting. Yes, so inhibition of normal degradation of acetylcholine leads to increased cholinergic activity. So that begs the question, how exactly is acetylcholine normally degraded? Well, acetylcholine is degraded with the help of an enzyme, and the name of this enzyme is acetylcholinesterase. Acetylcholinesterase has got two sites, an anionic site and an esteratic site. For acetylcholine to get degraded, it needs to bind to both these sites. So both these sites need to be free. When acetylcholine binds to both these sites, it undergoes degradation and is efficiently cleared from the plasma. Now, at this juncture, it is important to remember that there are two forms of cholinesterase enzyme. The one that we just discussed earlier, namely acetylcholinesterase, and another enzyme which is known by three names. This enzyme is called plasma cholinesterase or butyryl cholinesterase or pseudocholinesterase. Okay, so coming back to acetylcholinesterase enzyme. This is the enzyme responsible for degrading acetylcholine. It has an anionic site and an esteratic site. And for this enzyme to work efficiently, both sites need to be free. If this particular condition is satisfied, then acetylcholine will be able to bind to both sites, and this results in proper degradation of acetylcholine. Now, having understood this, how exactly do indirectly acting cholinergic drugs inhibit the degradation of acetylcholine? Such drugs block either the anionic site or the esteratic site or both. When that happens, acetylcholine fails to get degraded by acetylcholinesterase enzyme. The plasma levels of acetylcholine increase, and this means that there is more acetylcholine to bind to the muscarinic receptors as well as to the nicotinic receptors. The end result is increased cholinergic actions. Yeah, so any drug that blocks either the anionic site or the esteratic site or both would inhibit the degradation of acetylcholine. There would be more acetylcholine to stimulate the cholinergic receptors. The result would be increased cholinergic activity, and such drugs are called indirectly acting cholinergic drugs. So at this point, it should be quite clear that anticholinesterases, otherwise called acetylcholinesterase inhibitors, are powerfully cholinergic. It is true they act indirectly, but anticholinesterases are cholinergic drugs. Right, so indirectly acting cholinergic drugs, in other words, the anticholinesterases or cholinesterase inhibitors, may be classified broadly into two: reversible and irreversible. The reversible ones may be classified into carbamates and cerebroselective drugs. The carbamates may be classified into tertiary compounds and quaternary compounds. The tertiary compounds, which are smaller, can cross the blood-brain barrier and exert central effects. An example of such a drug would be physostigmine, which happens to be the drug of choice for the treatment of atropine toxicity. Quaternary compounds include pyridostigmine, edrophonium, and neostigmine, and we shall see the uses of these drugs in a short while. Cerebroselective drugs are able to penetrate the blood-brain barrier and enter the brain, where they stimulate M1 receptors and improve cognition. These drugs are extremely valuable in the treatment of diseases where cognition is impaired, like, for example, dementia. Examples for these drugs include donepezil, rivastigmine, tacrine, and galantamine. Now, the irreversible indirectly acting cholinergic drugs may be classified broadly into two: the organophosphorus compounds and the irreversible carbamates. The organophosphorus compounds may again be classified broadly into three: the nerve gases, insecticides, and others. Some examples for nerve gases include soman, tabun, and sarin. There are many examples for organophosphorus insecticides. Two of the most famous ones include malathion and parathion. Other organophosphorus compounds include compounds such as diflos and ecothiopate. Now, looking at this very rudimentary classification of OP compounds, it becomes clear that almost all these compounds have no therapeutic value whatsoever. They are used either as insecticides and pesticides or as bioterrorism compounds such as sarin. There is one exception to this, however, and that is ecothiopate, which can be effectively used in the treatment of glaucoma. The irreversible carbamates include carbaryl, propoxur, and others. As mentioned earlier, physostigmine is used in the treatment of atropine toxicity and any anti-cholinergic toxicity in general. Pyridostigmine, which cannot cross the blood-brain barrier, is the drug of choice for a disease that affects the skeletal muscles, namely myasthenia gravis. Edrophonium is not useful for the treatment of myasthenia gravis, but it is useful in diagnosis of myasthenia crisis. It is useful in distinguishing between myasthenia crisis and cholinergic crisis. And we shall discuss in much more detail about that on a separate video on myasthenia gravis. Neostigmine is useful in the treatment of postoperative paralytic ileus, in atonic bladder, in the reversal of neuromuscular blockade due to non-depolarizing agents, and in cobra envenomation. Now, it is useful and helpful to know that edrophonium binds to the anionic site and has a duration of action of hardly 2 to 10 minutes and is the shortest acting, indirectly acting cholinergic drug. Neostigmine, on the other hand, binds to both sites and has a duration of action that can extend to a few hours. Organophosphorus compounds bind specifically to the esteratic site, and it may have its action lasting for days. Now, the directly acting cholinergic drugs. These may be classified into cholinomimetic alkaloids and esters of choline. The cholinomimetic alkaloids include pilocarpine, eracholine, and muscarine, while the esters of choline include acetylcholine, betanacol, and carbachol. Now, these directly acting cholinergic drugs, like pilocarpine and carbachol, and the indirectly acting cholinergic drugs like ecothiopate, these are useful topically as anti-glaucoma agents. They can stimulate the M3 receptors in the longitudinal fibers of the ciliary muscle and result in increased opening of the iridocorneal angle. And obviously, when the iridocorneal angle opens up, there is increased drainage of aqueous humor via the trabecular pathway through the trabecular meshwork and up the canal of Schlemm. This results in a decrease in intraocular pressure. However, although 90% of aqueous humor does drain via the trabecular pathway, cholinergic drugs are no longer preferred in the management of glaucoma due to numerous adverse effects and the fact that they need to be instilled up to 5 or 6 times a day.